Okay, our next speaker is Greg Parkhurst, and he's going to make a case for phakic IOLs.
Well, thank you very much to the organizing committee for inviting me to present and make the case for phakic IOLs in 7 minutes. And by way of financial disclosure, I am a consultant to Star Surgical, who's the manufacturer of the ICL. According to a paper published in Ophthalmology just last year, myopia is projected to affect almost half the world's population by 2050. This is a 7-fold increase compared to the turn of the century. And in fact, 1 billion people worldwide are projected to have high myopia, many of whom are millennials in the workforce who stand to benefit in lifestyle, occupational fitness, and quality of life by having refractive surgery. The fact is, neither glasses, contacts, nor laser vision correction is ideal for every patient with myopia. Some patients have anisometropia. Their glasses are heavy and uncomfortable. Many have contact lens intolerance, and others have thin corneas and abnormal corneal topography. It's also important to note that phakic IOLs are not a new idea. In fact, Dr. Fyodorov developed the first prototypes over 25 years ago, around the same time LASIK was first being introduced to the United States. Since we can agree that many patients don't prefer to wear glasses or contacts and stand to benefit from having refractive surgery, we consider non-laser vision correction candidates to be the low-hanging fruit for phakic IOLs. We published a retrospective series of the indication for phakic IOLs in the military, all of whom were non-laser vision correction candidates themselves and had a job-specific reason for undergoing refractive surgery. For many of our nation's military members, glasses and contacts during combat simply are not an option. Reasons to undergo ICL in addition to their myopia included abnormal corneal topography, thin predicted residual bed, history of significant dry eye disease, and a few others. And in those patients, refractive predictability within half diopter was seen in 90% of eyes, and 96% of eyes achieved 20/20 uncorrected acuity. But should phakic IOLs only be for non-laser vision correction candidates? Long actually reported that for vision, phakic IOLs provide the best quality of vision, even more than other forms of refractive surgery such as laser vision correction. It's important to note that all forms of refractive surgery scored higher than contacts, and it's no surprise that spectacles came in last. We also published on a comparative trial of night vision quality that showed phakic IOLs to be superior to wavefront optimized LASIK for a matched population with moderate myopia. Phakic IOLs are also well within the skill set of the anterior segment surgeon and do not come at the large expense of hundreds of thousands of dollars in excimer laser equipment to get started. All one needs is an operating microscope, a few special forceps, and a basic cataract operating set. Post-op care is very similar to cataract surgery, with the important addition of monitoring vault of the phakic IOL postoperatively. One of the things that may have held phakic IOLs back from wider adoption to date may be the risks associated with intraocular surgery. So let's take a second to look at what the peer-reviewed literature has demonstrated regarding risks. First, any intraocular procedure comes with the potential risk of endophthalmitis. PARA has reported in a meta-analysis that the risk of endoph is approximately 1 in 6,000. None of the eyes in that series are known to have lost vision or lost their eye. The incidence of pressure spike requiring intervention is 3%, and the risk of pupil block after ICL is less than 1%. Cataracts are one of the risks that some surgeons also fear with phakic IOLs. In 8 peer-reviewed papers published between 3 and 7 years follow-up, all series except for one outlier reported that the clinically significant cataract rate is actually less than 2% of eyes. The Schmidinger analysis with a 17% cataract rate highlighted increased risk in the setting of very high myopia and older patients. Endothelial cell loss has not been shown to be a significant problem over time with the star collimer lens, although early remodeling during the first 2 to 3 years is thought to be due to the surgical event of the implantation itself. Trauma is another concern. Macaulay reported on a soldier involved in a grenade blast from 5 feet away 10 months after his ICL. In this case, shrapnel was seen in the orbit and a traumatic macular scar developed. However, no ICL subluxation or cataract formed during this obviously very significant blast injury. From a trauma perspective, some patients I've treated actually perceive the ICL to be less invasive than laser vision correction due to the lack of corneal tissue removal and any risk of flap injuries. Opportunities for future improvement in phakic IOL safety include better ways to size the ICL and minor design modifications, better diagnostics, and improved sizing nomograms. And we know that the sulcus distance is highly variable in any given eye. Accommodation certainly plays a role, as does the shape and anterior lens rise of the human crystalline lens. Given the good safety profile of Montes published results of a V4 ICL compared to a new ICL with a central fenestration, and this minor design modification has actually proven to have reduced IOP spikes and to date no cataracts. This is thought to be due to increased aqueous flow over the anterior lens epithelial cells. Given the good safety profile of the Visian ICL and the fact that many patients desire refractive surgery, phakic IOLs provide an excellent option which preserves the cornea and lens for the future. So when the cornea is borderline, one must ask themselves, would you rather implant a phakic IOL and leave open all options for presbyopia and cataract, or potentially risk the integrity of the cornea and possibly lead to the need for corneal transplantation? I know that for me and many of my patients, we choose phakic IOLs. In summary, we're facing a global epidemic of high myopia. Heavy spectacles and contact lenses are not acceptable for many patients. We as surgeons must help our patients balance the risks, benefits, and alternatives of all options for their myopia. Modern phakic IOLs offer high quality of vision, a low risk profile, and preserve the cornea and lens for the future. Phakic IOLs are definitely an important tool in the comprehensive refractive surgeon's toolbox. Thank you very much for your attention.
Thank you, Greg. That was excellent. And I think the key message is that we want to be comprehensive refractive surgeons. We don't just want to do one procedure for every single patient that comes to see us. And I really think that phakic IOLs have an incredibly important role for our high myopes that are younger, much better option than clear lensectomy. So, and the skill set is not that hard. If you're a gentle cataract surgeon, you know how to do the steps already. So I think that was a very nice paper.